I want to thank the series organizers for inviting me to present today. I am really pleased to see how many people are attending this series. It gives me great hope that you will take what you learn across the series to improve understanding and access to care for people with FASD. This work is often most powerful when you can leverage partnerships across systems of care. But even just one champion can make a significant impact. Maybe this could be you. My presentation today will focus on developing interventions for school-age children and adults with FASD. I believe it is critical to understand the lived experiences of people with FASD and their families and incorporate stakeholder feedback when developing interventions. Therefore, I'm going to begin the talk by reviewing what we know about the experiences of people with FASD. So what are the lived experiences of people with FASD and their families? First, stigma is a major challenge for FASD. Sylvia Rusin recently published a wonderful review in 2020 summarizing what we know about stigma in FASD. From her review of the literature, she concluded that public stigma is pervasive and severe. This can contribute to internalized self-stigma, shame, and guilt for people with FASD and their families. This contributes to underdiagnosis and low access to services. For example, many mothers are uncomfortable talking about prenatal alcohol exposure or seeking supports. Providers aren't comfortable asking about prenatal exposure or are afraid to label a child or an adult with FASD. This often results in people with FASD feeling less than others. Stigma is also a major contributor to systems-level barriers that interfere with diagnosis and access to care. Qualitative research conducted in our lab and others has identified a number of system-level barriers. These barriers include a delayed diagnosis, difficulty qualifying for services, and low availability of services in community settings. Furthermore, once services are in place, they're not always implemented very well as many providers don't get training in FASD. And then there is often a push to remove services once a child is showing benefit, but oftentimes these services are critical to maintaining those gains and accommodations. All of these barriers have been associated with a lack of knowledge about FASD in systems of care. Many of these barriers have been found in studies in other parts of the United States as well as internationally, and increased access to services and provider education and training are desperately needed. That's, I think, why we're so glad to have all of you here today. Another challenge for people with FASD is that their symptoms are easily misinterpreted as willful and ineffective strategies are used. This results in a lot of frustration for the person with FASD as well as their families and other adults working with them. This image summarizes findings from a study we did in my lab in 2016. When parents knew more about FASD, they were better able to reframe or recognize the neurodevelopmental disabilities contributing to their children's behavior problems. As a result, they use much more effective accommodations and strategies to support their needs. This leads to increased competence and efficacy for everyone. The experience of having an FASD typically means feeling different. People with FASD often have some awareness of their difficulties and find them limiting across multiple aspects of their lives. They experience discrimination and feel undersupported. FASD can also feel really unfair, and many people may have difficulty coping. This can result in mental health problems and other life challenges. Despite this, many people with FASD have a great strength of persistence as they try to overcome these challenges and do their best. It is also important to consider the experiences of caregivers and other supporters of people with FASD. Given the lack of support and access to services, caregivers become the primary advocate for people with FASD and have to take on many roles. They have to support the needs of their child or adult with FASD and fight against systems barriers, often interfering with what their children need. This results in a high level of stress across systems and levels. Caregivers describe a really protective parenting attitude and work hard to educate themselves and take actions to put protective factors in place. While these protective actions are critical for the individual with FASD, they also contribute to more stress. Although most research on FASD has focused on deficits and barriers, there is starting to be more study of the strengths and capabilities of people with FASD. Most of the research on strengths in people with FASD have been done with case studies or small groups of adults with FASD. This word cloud pictured here is from a study my graduate student and I have under review that asked parents of children ages 4 to 8 with FASD about their children's strengths. The word size reflects the number of times a strength was named. Several themes emerge about the strengths of people with FASD. These include things like social motivation. They describe their children as friendly, caring, loving, affectionate, and almost every parent in our study gave an example in this category. Children also displayed persistence and resilience. There was individual aptitudes and skills such as being artistic, athletic, intelligent. And parents described their children as having positive mood and characteristics such as being happy, curious, or adventurous. We also asked parents about the positive influences their children have on their families, and their responses included things like bringing about social or family togetherness, emotional contributions to the family, tangible contributions such as helping with household chores, and parental and personal growth for caregivers were also discussed. I want to take a moment for this kind of key take-home message. I want to emphasize that people with FASD are capable. The key is that we provide opportunities and supports for people with FASD to use their strengths and abilities in meaningful activities and relationships. And think about the role that you can play in this. As we turn to think about interventions in FASD, I'd like to present a new framework my students and I have proposed. We are calling it the From Surviving to Thriving model for intervention development. As you can see here on the left side of the slide, much of what we've learned over the last 40 years has documented deficits, barriers, and how people survive with FASD. Surviving with FASD often means feeling different and experiencing stigma, as I've discussed. Often, FASD-informed care is not available, and treatment approaches in the community tend to be deficit-focused. Deficit-focused interventions can be prescriptive and focus on fixing the problem. As a result, problem or deficit reduction are often the primary outcomes examined. The From Surviving to Thriving model proposes a paradigm shift towards a strength-based perspective. As you can see on the right side, this perspective places greater emphasis on investigating the personal strengths and supports that allow people with FASD to thrive. Surprisingly, we know as a field pretty little about the strengths of people with FASD and the supports that are most helpful across the lifespan. This view also challenges us to rethink the intervention outcomes we're targeting. What does thriving even look like in FASD, and how do we measure it? Strengths-based interventions tend to be person-centered and holistic. They help the person identify what outcomes are meaningful for them and the strengths and resources they already have, with the goal of addressing challenges that are interfering with their quality of life. Additional skills and natural and specialized supports, if needed, are selected collaboratively by the person and provider to help the person move closer to their goals and values. For this paradigm shift to be successful, 3 significant barriers need to be addressed. These include effective strategies to increase awareness and understanding of FASD, increase access to care, and reduce stigma. Addressing these barriers will be necessary to allow people with FASD to thrive at a population level. However, these challenges alone are insufficient. Changing how we view people with FASD and adoption of a strengths-based approach to intervention will be essential. We will also need to plan for dissemination and implementation. So how are we doing in developing and studying interventions to help people with FASD and their families thrive? It took quite a long time from the recognition of FASD in the early 1970s to the first intervention trials in the early to mid 2000s. But there's been nice steady growth since the mid 2000s. Importantly, research shows people with FASD and their families benefit from interventions. Most interventions developed and tested have been in the preschool and school-age period. Many target the domains you see here on the right, such as self-regulation and attention, social skills, academics, and parent training and support. Many of these interventions target skill building and environmental supports that are fairly progressive in the field. Most recognize strengths in the conceptual model or intervention design, but outcome measurement has largely focused on deficit or problem reduction so far. Next, I want to highlight just 2 exemplary interventions that are attentive to creating supportive environments and building skills. Both of these programs also have materials and trainings that are available online. The first is the Families Moving Forward program developed by Heather Carmichael Olson at Seattle Children's Research Institute and the University of Washington. It's a caregiver-focused intervention that integrates psychoeducation and support, motivational interviewing, cognitive behavioral strategies to help change parent attitudes and behavior, positive behavior support to target challenging behavior, and assistance with advocacy and education. It's typically delivered over 15 to 21 sessions. It has shown positive family outcomes across parent attitudes, their sense of competence as a parent, increased family needs met, and improved child adaptive behavior and reduced problem behaviors. The second intervention is the GoFAR program developed by Claire Coles and Julie Cable at Emory University. It tested individual sessions with children learning what's called the FAR technique, which is focus and plan, act and reflect, using an innovative computer game. There are also parent training sessions to help with self-regulation and understanding this approach. Next, there are joint parent and child sessions where they focus on using this FAR technique on specific real-world situations relevant for the child and family. This program has improved adaptive functioning in the children, attention, and behavior problems, and you can see the link there of where you can learn more. While there has been great progress, a number of critical areas for growth remain. These include increasing accessibility of evidence-based interventions in the community, targeting areas such as early childhood, adolescence, and adulthood, which have received very little study. We also need mental health interventions, as many people with FASD have significant difficulties with mental health symptoms across the lifespan. We also need to move towards a holistic and person-centered frameworks, looking at measurement of strengths and thriving, and really working at the systems and policy level to make change. Given the low access to care for FASD interventions in the community, my team and I are testing the utility of mobile health interventions for people with FASD and their families. Mobile health offers possibilities to reach a large number of people at times and places convenient to them. Most adults own a smartphone, and this has great potential for scalability. Apps are also really well suited for many things like providing information, self-monitoring, and communication synchronously in real time. Both of the projects I'm going to be talking about are part of the collaborative initiative on FASD. Both are utilizing mobile health to increase access to care across the lifespan. Our first project is targeting parents and caregivers of children ages 3 to 12. Pictured here is our multidisciplinary team working on this project, including my co-principal investigator, Cristiano Taparello. We began this project using the standard Families Moving Forward program, which is a tailored intervention developed by Heather Carmichael Olson and her team at University of Washington and Seattle Children's Research Institute. Families Moving Forward is a 15 to 20 session program delivered by a trained mental health specialist that I showed a bit earlier. For this project, we're creating a derivative product of the standard FMF program, which also integrates new features and is versatile and scalable. The learning content, principles, and many methods have translated remarkably well to an app format, but it's also been a pretty complex process. Here is an overview of the components of the Families Moving Forward Connect app. First, you can see here in the center is the main screen for what we call the learning modules. The learning modules have 12 core modules that are divided up across the 3 levels you see here. They include educational text and videos to teach parents important skills, and also exercises to practice this new content. There is a notebook where the exercises are saved, and it creates a personalized section for later reference. There is also a dashboard that has an avatar that the user creates for themselves and includes summary of progress as well as a behavior tracking tool. There is also a library where families can go to watch videos, read fact sheets, and find more resources to extend their learning. And last, there is the Family Forum, which is where users can go to share ideas with other families in real time, and it's organized into subforums that are moderated by trained peers. And here is just some of the screenshots of these different components you can see here. In developing the Families Moving Forward Connect app, we have been taking a systematic, user-centered design approach to development and evaluation. Throughout this process, we have engaged key stakeholders to get their feedback through each step, which has been a real strength of this approach. First, we conducted focus groups in 5 cities in the United States to get input on our initial design. Caregivers were overall very positive about the app. They identified positives including the app being accessible, providing guidance and organization of materials, offering caregivers opportunities to connect, and including materials that could be shared with others. Next, we developed prototypes of the app incorporating this feedback. In 2019, we then did 2 rounds of beta testing of the app with families and providers. We looked at usage analytics and did focus groups and interviews to better understand the user experience. This process was incredibly useful and led to new refinements of the app to enhance and add new functionalities. Then we conducted a larger feasibility trials with a total of 105 caregivers in 2020 to 2021. These let us continue to get feedback from users and improve the app, but it also let us try out study procedures we're going to need for our larger randomized controlled trial. This process increases our chances of our RCT being successful. Caregivers rated the quality of the app highly, and we found some small to medium trends and changes in child behavior and parenting that are really promising. We are now enrolling families for our randomized controlled trial in the United States. This study will let us directly test how effective the app is for families and if it produces significant improvements. Next, I will share a bit with you about an exciting study we're conducting in partnership with the Adult Leadership Committee of FASD Changemakers, and you can see many of our partners pictured here along with our team. Partnering with the Adult Leadership Committee of the FASD Changemakers has been an integral part of this project. They ensure we ask the right questions, avoid stigma, and take a strengths-based approach to the tools that we're developing. We're developing the app called My Health Coach. This app was inspired by the fact that there has been such little attention and evidence-based supports for adults with FASD. Our partners have documented significant physical health and quality of life concerns with their peers in 2 surveys that they call the Lay of the Land surveys. The first focused on physical health and the second on quality of life. Also, the mantra, nothing about us without us, has been important in our process. The My Health Coach app is based on self-determination theory for wellness proposed by Rich Ryan and Ed DC at the University of Rochester here. This theory proposes 3 core psychological needs that relate to motivation and wellness. These needs include autonomy, which means how much control or independence a person feels in making choices in their life. Competence, which is to feel you're doing a good job. Relatedness, or how connected you feel to other people. How well a person's needs in these 3 areas are being met influences their motivation and engagement in everyday life. This affects a person's physical health and quality of life, 2 areas that are important to adults with FASD. So in the My Health Coach app, we're targeting ways to help adults feel more competent, in control, and connected with others. The supports within the app can help adults manage their FASD more independently and meet their self-advocacy and wellness goals. This can help improve their physical health and quality of life. By designing this as an app, we make these supports more accessible to people with FASD. Our team has been hard at work co-designing the My Health Coach app this year. We've developed an interactive prototype of the app so far. Here are just some sample screenshots to show you a little bit about the general design of the app. The My Health Coach app uses a chatbot interface. This makes the experience of the app simple and easy to use. It feels just like you're texting with someone. We are also using what is called a just-in-time design, which means that the app offers tools and information to people when they need it or want it most. So the app will ask the user a question. If they don't respond or say not right now, the app tries back later when the user is more receptive. It also uses the person's answers to offer specific information or tools within the app that are most relevant to that person. Here are just some of the features pictured, including a daily check-in, a tracker tool that lets the person track and get prompts for things important to their daily life, such as medication or exercise. The app also includes a daily message, calming tools, and materials the person can use with advocacy with providers. I want to thank you so much for your time and attention. I also want to acknowledge the National Institutes of Alcohol Abuse and Alcoholism and the Collaborative Initiative on FASD for supporting this work. I also want to appreciate the generous support of Jay and Constance Mazelsky in this work that I've presented today. Finally, I'm happy to take any questions or comments or feedback that you may have today after watching this presentation.